Hey everybody, this is Miss Shoemake, and I'm just going to introduce you to postpartum right now. When we have a lady that is postpartum, whether she's a vaginal or a C-section, we need to have our assessment in tune to complications that could come really quick. So of course, we need to do a head-to-toe assessment, everything you learned since nursing 1. So we need to listen to their heart, their lungs, of course their bowel sounds, especially if they had a C-section. We need to make sure their bowel sounds come back. Don't forget their IV sites, their capillary refill, any edema, are they peeing, things like that. But we're also going to add what's called a bubble heat to our assessment. Okay, so I'm just going to minimize me because you don't need to see me. Okay, and here is our bubble heat. So we're going to do our head-to-toe assessment plus the bubble heat. Okay, so it's simple B-U-B-B-L-E, bubble heat, like you see. The first B is the breast. Okay, first of all, is our mom's breast or bottle feeding? If they're breastfeeding, how's it going? Is the baby latching on correctly? If the baby is breastfeeding, the mom's nipples can be really, really sore. So we need to assess them. Are they dry, cracking, or are they healthy? We could get her lanolin for her nipples. It's a protective mechanism to help, when the baby latches on, it could really tear up that skin. So lanolin will help heal that. But also the mom's own colostrum is fantastic. So it not only has the healing and protective components, but it has those proteins that do help it heal. So if mom does not have lanolin, her breast milk will almost even work better. And it's free, right? You like free. If she is bottle feeding, then we want to make sure the mom knows what to do with her breasts. Okay, so if she is bottle feeding, we do not want any nipple stimulation, none whatsoever. So she should wear a tight sports bra, or they used to wrap the breast in ace bandage, but now they just kind of wear a tight sports bra. No nipple stimulation whatsoever. So even in the shower, have the water hit her back and not her front, because the water of the shower will cause nipple stimulation, which will tell the brain to keep making milk. Her significant other needs to keep their hands off, no touchy, until that milk is dried up, because that will keep making milk as well. Okay. And we look at the size, the shape, engorgement. We may put like a warm compress on it or things like that, or even ice. May help the patient as well. But we just, basically just assess her breast. So that's the B in bubble heat. The uterus. After a patient delivers, we want the uterus to be nice and firm, like a coconut or a softball. Okay. If it's not firm, it's what's called boggy. Boggy is bad. BB, boggy, bad. So we don't want a uterus ever to be boggy. And what I tell my patients when I'm assessing their fundus, their fundus is the top of their uterus. Okay, so I'm just going to stand up. So here's my belly button. Okay, right here. After a mom delivers her baby, whether it's vaginal or C-section, that uterus will eventually rise and rebound back up to the level of the umbilicus. Okay, and that's the U. Tomorrow, the uterus should be -1, 1 finger breadth below the belly button. In 2 days, it should be 2 finger breadths below the belly button. In 3 days, 3 finger breadths, so forth and so on. Okay, the uterus should always be midline. If it's to the right or to the left, that bladder can actually be pushing it to the right or to the left. And so we always want it midline, because if there is something pushing it to the right or to the left, it may remain boggy and not firm up like we want it to. Okay, so with the uterus, we're going to massage her uterus. And if we feel it that it's boggy, we could almost feel it tighten up and contract and firm up underneath our hands. It's amazing that we can do this. Okay, we want to measure where it is. So if it's at the umbilicus, if she just delivered this morning, it might be at the U. If she delivered yesterday, we might be -1, -2, so forth and so on. It should always decrease. It should never go above the belly button. Okay, that's something pushing it out of the way, maybe the bladder or even gas, or it could just be displaced. So we always want it below the belly button. Okay, so of course we need to make sure our patient is urinating on a regular basis. Sometimes, and it sounds silly, she may forget to urinate. She may have a lot of visitors. She may be so tired that she really doesn't feel like getting out of bed. The baby is poo and pee and eating constantly. So we have to remind her, don't forget to pee. Okay, so that uterus, is it firm or is it boggy? Is it midline? Where is it? Okay. When that placenta is delivered, and there's what's called placental sealing that happens almost immediately to prevent postpartum hemorrhage, and we're going to massage and you could feel that uterus firm up like a coconut. Okay. When we assess our patient's fundus, we're going to lay them flat down. Okay. And we're going to support the bottom of her uterus for camera purposes. I'm just going to pretend this is the bottom of my uterus. And then we're going to massage with the other hand. Okay. Is it going to hurt them? Yeah, probably. Whether they had a C-section or a vaginal birth, this isn't comfortable. So I'm explaining, as I'm massaging their uterus, I'm explaining the importance of it. And I always ask my patients, has anybody ever told you why we have to do this? 99% of the time they say no, even though I know some darn good nurses do tell them why we do this, but I tell them anyway. The reason why we have to make sure their uterus is nice and firm is, I say, picture a car sponge, one of those big old sponges that you wash your car with. When it's sopping with water, it's boggy. Okay, so it's kind of like the uterus is soaking up extra blood because there's active bleeding in there. We don't want it boggy or soaked with blood. So as I massage it, I'm wringing out that extra blood, and so we could feel it firm and dry up underneath my hand. Now, what causes bogginess? Sometimes just a tired uterus. If they were in labor all day, that uterus is a muscle. So it could just make the uterus doesn't feel like firming up. Okay, they may need extra help, maybe medicinal help. If there's a piece of placenta in the way. So when the placenta is delivered, you'll see the doctor like looking at the placenta. And you're like, what in God's name are they doing? What are they looking for? We're making sure it's all there. Because if there's one piece of placenta in the way, that uterus is not going to firm up like we want it to. The uterus will detect that there's something in there that's not supposed to be there, and it won't firm up. Okay? And maybe there's a clot in there. So sometimes if the lady's laying down for a long period, there'll be blood that's pooled, and it will eventually coagulate. And if that's in the way, it's not going to firm up like we want it to. So we may have to remove that clot, or the labor nurse declots, will declot the patient, or even the physician. But if there's anything in the way, the fundus, the uterus won't clamp down. Okay, so we always want it firm. A firm uterus is good. That first hour initially after delivery is the most important. Whether it's a vaginal or a C-section, it's the most important period of recovery. We're going to assess that fundus every 15 minutes for that first hour. Okay. Then we're going to look at her bladder. Is it distended? If she has an epidural, she will have a Foley because she can't get out of bed with an epidural to go pee. Okay, but if she's going natural, again, we have to make sure that that bladder is empty, because any little bit of urine in the bladder could displace that uterus, and again, that will make a boggy. So we don't want a boggy uterus. Boggy's bad. Okay, so we always want an empty bladder. If she had a cesarean, of course she's going to have a Foley catheter as well. So that's usually discontinued. It depends on the hospital's policy, but it can be up to as early up to 6 hours after delivery removed. So we just have to make sure she urinates within the prescribed time after removing that catheter. Okay. What does the urine look like? Is it clear? Is it cloudy? Is it dark? Is she making enough urine, at least 30 cc's an hour? So that's just normal med-surg stuff that we have to apply and assess. Her other B, bowel movement. It used to be back in the day, they used to have a bowel movement prior to discharge, and that's no longer. With a vaginal discharge, as long as the baby's healthy and the mom is healthy, then they could be discharged within 24 hours of birth. And so if she was NPO or on ice chips the day previously, she might not have a bowel movement. And so as long as she's passing gas, that's good. Okay. But if she is very swollen on her perineum, or if she has a laceration or episiotomy, we want to make, she's going to be afraid to have a bowel movement. So we want to make that as easy as possible. So provide her with lots of water, get her a stool softener, help that lady out. Get her a stool softener, because chances are she's going to be on pain medication, and pain medication has tendencies to constipate. So let's help this lady out, okay? Get her some dermaplast spray for her bottom, just to help the stinging. That's kind of lidocaine spray. She has an episiotomy or a laceration. Again, she's going to be afraid to bear down, so we need to help her out as much as possible. Okay. L in bubble is a fancy name for bleeding. It's called lochia. Okay. And lochia is just bleeding. So, but in your nursing notes, instead of saying the woman is bleeding, you want to use the term lochia in this kind of population. Okay, so we want to look at the amount of lochia, the odor, the color, if there's any clots. There should not be any odor. If there is, there's some kind of infection that may be brewing. She may have some small clots, dime-sized clots, but she shouldn't have anything large. And if she keeps passing them, we have to investigate why she keeps passing clots. Now I'm going to jump back up to the uterus. When we're massaging that uterus, remember, we're wringing out that sponge. Okay. So that patient may feel, oh, there's something that just came out. Remember, we're wringing out that sponge, so she may have extra lochia coming out. That's normal. And we have to tell her that's normal. Okay. Lochia rubra is the color that we'll see when we're in the clinical or in the hospital setting. Rubra means red. Okay, so lochia rubra, that's what we would document. We would document the amount if it's a large amount. If it's a large amount and covering the pad, that is not good. If it's a scant amount, maybe like a dime size, quarter size on her pad, we would document scant, small amount. And you'll get this more in the postpartum lecture. But the woman should never, ever saturate a pad more than an hour. Okay, so if we go in and we see her red lochia, rubra, saturating her pad, we would ask her, when was the last time you changed this? If she just said, oh, about a half hour ago, okay, we got to assess that fundus. We got to lay our hands on the fundus and see if it's firm. Okay, and we got to figure out why she's saturating that pad in an hour. The E in bubble is episiotomy. Okay, not all women have episiotomy, so of course you wouldn't want to say, let me check I'm going to assess your episiotomy if she had a C-section, right? But an episiotomy is an intentional cutting by the doctor. A laceration is a tear, when the skin tears during the vaginal delivery process. What we're assessing for is the location, the sutures, making sure they're intact. These will be dissolvable sutures, so we don't have to, snip them and remove them. But they do dissolve. If there's any edema, again, let's get this lady some ice. If there's any redness, swelling, a lot of times the perineum will be swollen after a vaginal delivery, and that's normal. But again, let's get her some ice. Let's get her that dermaplast spray to help take some of that sting away. Okay. H in he used to be Hohenstein. I could not find anything that did not say Hohenstein for this picture purpose. But now, because they say dorsiflexion of the foot can actually dislodge a clot if a patient has one. But it is important to mention that if a patient has, calf pain when walking, or any kind of redness, sharp pain, warmth in that leg, it still could be a DVT. So it's still is part of our assessment as well. We just don't dorsiflex the foot back. The H in he now stands for hormones, and it kind of goes with the E in he, emotional status. So hormones and emotional status. How's she doing? Those postpartum hormones, as soon as that placenta is delivered, all those hormones go, and it's mind-blowing how the body's like, oh my God, what's going on? And the hormones are up and down, up and down. How's she handling all this? Is she tearful? Is she bonding with that baby? Is she crying hysterically, or is she fine? Okay, so it's things that we have to look at, and it's really important, especially if we do see tinges of postpartum depression. We need to note that, because that could continue to spiral downward. Okay, and we don't want any postpartum depression, because it could become postpartum psychosis. Postpartum blues happens in 80% of women. So if you walk into your patient's room and they're crying, and you're like, oh, what's wrong? Are you okay? And they're like, I don't know why I'm crying. I just feel so stupid. I don't know why I'm crying. You need to let this poor woman know that this is perfectly normal, and this is all hormonal related. Okay? And it's usually it's in the discharge instructions too, so it's in black and white, so she could prove to her significant other, like, hey, I'm going to have to be a nutcase. Okay? But the hormones are crazy. Okay, most importantly, we just want to make sure it's not postpartum depression, and teach her the signs of postpartum depression, so she's alert enough, so she aware enough, so she can get help, and her significant other, so he or she could is aware what the signs of postpartum depression are. Okay. If she doesn't feel like getting out of bed, if she doesn't taking care of herself, if she's not paying attention to the baby at all, she just they're signs, and especially if this is not my significant other was not like this before she had her baby, she needs to go be seen. Okay, so that's bubble heat. So as with our head to toe assessment, we're going to add this bubble he assessment. Okay, and usually in the clinical unit, I make my students do initially their full head to toe, including the bubble he, and then with their next set of vital signs, do the bubble he again, because honestly, you can never massage that fundus too much. Okay. Just going back to that uterus, because it's so important. What makes the uterus boggy? I already mentioned that if it's tired, if there's a clot in the way, if there's retained placenta in the way. But let's think about this. What if the woman had twins or triplets or quadruplets or anything more than that? That uterus is doubly, triply, quadruply stretched. Okay, and it's going to take that much more effort to shrink back down to its pre-pregnancy size. So that's another reason if a patient has a boggy uterus, how many children did she have? Did she have twins, triplets, things like that. Okay, so again, you're going to get this in your postpartum lecture, but it's always good to hear it, at least to have it being introduced to you a little bit. And then when lecture, be like, okay, yeah, I get this now. Okay, so that is basic, the postpartum brief assessment. If we were in person, I would also talk to you about catheter placement as well, because we talked about the bladder. I would also review catheter placement. If you have never put a catheter in, a man or a woman, go ahead and review your technique. Okay. Like I said, most of our patients would get catheters. We don't see a lot of natural, but there's some women choose to go natural. But if they choose to have an epidural, or of course if they need a C-section, they would have a catheter placement. So I would always remind students, even though you were checked off in level 1, please review your catheter placement. Okay. I don't have at school, we have, I have a torso that I would demonstrate on. But I always give my students this tip that I think really helps. When you put a catheter in a pregnant woman, it's probably the least intimidating patient that you'll have to put a catheter in, because most of the time she has the epidural, and it helps her nerves, which will help your nerves. And she could feel you, but she can't feel you. Okay, but with a catheter in a woman, it could be really tricky. So with my mannequin, I would be showing you with, of course, you have your sterile gloves on. I'm trying to keep my hand in the camera lens. You would you have to place your fingers inside the labia. Okay, so we need to know our patients very well. So we need to put our hands inside the labia. So when we spread the labia, we're not just spreading skin, we're actually spreading inside the labia to see the meatus. Once I spread open the labia, I'm going to pull my hand back on her pubic bone, okay, and to rest it, because she probably has lubricant down there from cervical checks. Her water might be broke. It's kind of a hot mess, and it's very, very, very slippery. And so I've seen students like hands, because they have to keep that labia open and they're nervous. They start shaking. So if you just kind of pull back, I call it the claw method, pull back on that pubic bone, have it rested there, the meatus will be like, oh, and you'll be able to see it better. Okay, this works on your elderly patients as well. So when you're in med surg, you're in 220, the meatus will be more easily found. Okay, so this is just a short intro on postpartum. Thanks for listening, and we'll talk to you soon.